everybody. Welcome to the fourth edition of the ISO Virtual Multidisciplinary Joint Clinic. This month being the new year of January is incidentally also the Cervical Cancer Awareness Month. Going with that same theme, we decided to have a multidisciplinary joint clinic on cervical cancers. Of course, the good news in cervical cancers is the incidence is decreasing. Of course, the decrease has been there through several decades. And of course, you have also have a WHO call for elimination of cervical cancers, although that goal seems to be pretty lofty. But nonetheless, I think it is one of the cancers that the WHO considers worthy enough to be eliminated, and possibly sometime in this century, hopefully. And also you also have multiple the formula given by the WHO 90-70-90 formula towards management of this. So all this we will cover through the course of a talk initially on the consensus guidelines on vaccinations and cervical cancers, and subsequently a panel which would be moderated by Dr. Umesh. I would leave it to Dr. Richa to sort of set the context for the program. Over to you, Dr. Richa.
Okay. So good evening, everyone. As you know that cervical cancer continues to pose a substantial burden on women's health globally, and particularly in India, in which it is still the second most common cancer. So despite the global progress, India's mortality rate with close to 80,000 deaths every year is disproportionately high, which is around 11.2 per 1 lakh women, which is much higher than the global average of 7.1 per 1 lakh women. So definitely we need to do something. And, prevention is one of the best way. Luckily, we have HPV vaccine. If you talk about the path of HPV vaccine in India, it has been lengthy and challenging. Ever since it was approved in 2008, we had some, government-sponsored programs in Delhi, Punjab, Sikkim with success. However, recently, in a very welcome and recent development, during the interim budget of 2024 and 25, the Union Minister, Mrs. Nirmala Sitharaman, she proposed cervical cancer vaccination to girls aged 9 to 14 years. And recently, in my state of Bihar, the government has proposed free vaccination for all girls in the adolescent age group. So with all these, I think it's a golden opportunity for all, stakeholders, all healthcare professionals to work in a united way so that we can make our way for elimination of cervical cancer. So we are going to start with consensus guidelines. And to present the guidelines, we have Dr. Amita Maheshwari, ma'am. Ma'am,
probably, I'm not sure she has joined. Otherwise, we can start with the panel first.
We can start with the panel. Issues. So we know that comprehensive cervical cancer control includes a multifaceted approach to detect and treat early cervical cancer successfully. And to moderate the panel, I now invite a very well-known eminent radiation oncologist, Dr. Professor Umesh Mahanshetty, who is the Director, Homi Bhabha Cancer Hospital and Research Center, Visakhapatnam. Welcome, sir.
Thank you, Dr. Richa, for that kind introduction. Can I share the screen?
Yes, sir, you're visible.
Do you see my screen?
Yes, sir, it's visible.
Yes. Okay. So at the outset, I would like to thank ISO for this kind invitation, and the mandate given to me as a moderator is to have a panel discussion on evidence-based management of early-stage cervical cancers. So I have esteemed panel members, including gynae oncologist, radiation oncologist, and medical oncologist. So I would request each of the panelists to kindly introduce themselves. Dr. Rohit.
Sir, he will join soon.
Yeah, rest
Okay.
of the
So, yeah, Dr. Satinder.
Madam, you are muted. Satinder,
Unmute yourself, please.
Yeah, sorry.
And
Good evening, everyone. Hi, I'm Dr. Satinder. I am a gynae oncologist in Max Super Specialty Hospital, Vaishali in Delhi, NCR. And I've been trained in Tata Memorial Hospital, Mumbai. Sir knows me well. And thank you for having me here.
Thank you, Dr. Satinder. Dr. Harjot.
Madam, unmute yourself.
Unmute yourself. Yeah.
Good evening. Am I audible?
Yes, please go ahead.
I'm Dr. Harjot. I'm working as a consultant radiation oncologist at American Oncology Institute, Hyderabad.
Thank you, Dr. Harjot. Dr. Vinita Goyal.
I'm Dr. Vinita. I'm a radiation oncologist at Fortis Hospital, Delhi.
Yeah. Do we have Dr. Aditya Murli?
Hi, I'm Dr. Aditya. I'm a medical oncologist. I work at Apollo Hospitals in Bangalore.
Dr. Vikas Talrecha.
Sir, he is joining soon, sir, in 2 minutes, sir.
Okay. So thank you very much, all the panelists for being on time for this panel discussion. So to set the ball rolling, I've just put on some initial slides. So going to the definition of early stage cervical cancer, it is the unconventional stages, which includes T1A2, T1B1, and T1B2. And I'm glad that ISO has selected a very early stage cervical cancer for panel discussion, but because invariably most of the panel discussions or debates are always on the borderline cases of early versus advanced stage. But nevertheless, let's see what we have lined up for this panel discussion. So for all the panelists, it is T1A, T1A2, T1B1, and T1B2. So to dig out the evidence-based management discussion in detail, I have put up this case capsule, and this is a 40-year-old young woman who had no comorbidities, family completed, sexually still active. Cervical biopsy showed a squamous cell carcinoma. There was no lymphovascular space invasion on biopsy taken. And clinically, this patient had dimensions of width roughly around 3 centimeters, thickness 3 centimeters, height 3 centimeters. Suffice to say that the maximum dimension or diameter would be roughly around 3 centimeters. So my first question to Satinder as a gynae oncologist is, do you need any additional information for further assessment for this patient if this patient comes to your clinic?
Thank you, sir. So clinically, she is 1B2. The tumor size is around 3 centimeter. But yes, that's a clinical thing. So we definitely need little more information. First, from the cervical biopsy, you have said it is a squamous cell carcinoma. If possible, I would also like to know the grade of the tumor. I would like the pathologist to tell me the grade. You have already told about lymphovascular space invasion. And then again, I would like to get an MRI done if the facilities are available for an MRI pelvis with contrast, with preferably diffusion and dynamic contrast enhancement if it is there, for assessment of the size of the tumor, for parametral invasion, and for the assessment of regional lymph nodes. And in case the facility for MRI is not available, then definitely a TVS is also a very good modality. And probably, I think 3 centimeter and 40 years, there should not be any confusion about parameter. But if there is any doubt on clinical examination, we can also go in for an examination under anesthesia if it is a doubt.
Okay. So do we have Rohit also on panel now? Not yet. So then I would put this question to Dr. Harjot and Dr. Vinita. Anything additional you would like to have?
So, hi, I'm Vinita. I agree with what Dr. Satinder has just now said. But anyway, I think that in case MRI is not available, I would want a 3-dimensional imaging and would consider doing a contrast CT scan of the abdomen or pelvis.
Okay. Anything else, Harjot, you would like to add?
If the patient undergoes an MRI, I would also like to see if the tumor is going close to the stroma or not, which can be detected on MRI, so that we get an idea about whether this patient would require any adjuvant therapy or not in future, to decide which option would be the best for the patient. Nodal assessment I would do by CT abdomen.
Okay. So given the case that maximum diameter is around 3, so both all the panelists agree that we need imaging modality both for assessing the primary tumor as well as the regional nodes, because there is a significant risk of lymph node metastasis in a given scenario. Thank you very much. Dr. Samir or Dr. Richa, you have to help me with if there are any questions in the chat, then you'll have to interfere and tell me about this.
Sure,
So,
sir. Sure, sir.
well, as per the consensus of the panelists, we did do an MRI for this, and MRI did show that the primary tumor is in fact 3.5 centimeters, and you can see the sagittal section on the right side and the coronal section on the left side, which shows a nice proliferative tumor at cervix, essentially an ectocervix lesion, mainly the posterior lip. The endocervical lesion, inner cervical region looks absolutely normal, and on coronal section, we can nicely see that there is no breach in the cervical stroma seen on either side, so suggesting that there is no parameter invasion, and there are no pelvic nodes, significant pelvic or paraortic nodes on CT done for this patient. So with final stage diagnosis of T1B2N0, we would like to ask the panelists now, maybe first surgeons followed by radiation oncologist and medical oncologist. Maybe you can choose one or two options of this option which are shown in this slide. So what would be the treatment options and which one would you choose? Let's start with surgeon, Dr. Satinder.
So I'll go for a type 3 radical hysterectomy with BPLND. With bilateral salpingectomy, O is slightly doubtful for me. She's 40 years, probably oophorectomy, and it is a squamous cell carcinoma. I would like to discuss with the patient. If the patient wants to preserve the ovaries, probably I'll preserve them and would like to do an ovarian transposition along with it.
Okay. Since you are the only surgeon, I would like to ask you, what would be your second choice?
Second choice will definitely be a radical chemoradiation.
Okay. So coming to radiation oncologist, Dr. Harjot.
I will give both the treatment options to the patient, and I would suggest that radical chemoradiation has equivalent outcomes to radical type 3 hysterectomy. So patient can choose either of the options, and patient may land up with adjuvant radiation later. Sometimes if surgery is done, and it is always better to have one modality than two modalities. So I will discuss the pros and cons of both the options. But I will discuss regarding radical chemoradiation as well, since it is equally effective and less toxic with the modern technology.
Yeah, just choose the treatment option. I will
Radical,
not. I will wait for justification later on. Yep, Dr.
radical.
Vinita.
Radical CTRT.
Okay. So my medical oncology colleagues, Dr. Talreja.
Sir,
So this
Aditya sir is
patient.
here.
So yeah, go ahead. Go ahead.
To be honest, sir, I have no input on this because whatever the MDT decides, I'm surely not going to come into this. Maybe I'm a little biased towards surgery, but then again, I would go with the MDT decision on this.
Okay. Aditya.
That was me speaking, sir.
Okay. Okay.
Yeah.
Okay. So looks like medical oncologist feels that he has no role in early stage cervical cancer, but I will rope in him.
But sir, if I can
again.
qualify that,
Uh-huh.
by saying that both the trials which have been causing a lot of strife in cervical
No, let's
cancer.
not discuss the trial discussion.
Exactly.
I will
So
come
that's
back
why
to
I'm
that
keeping.
later on.
Yeah.
But what I'm saying is I'll rope in you again because there are some indications for chemo as well. So anyway, so it's good that we are getting different opinions from different experts. That makes this panel discussion more interesting now. So let's go to next question. Let's say this patient was only 32, married, and she wants to conceive. So, Dr. Satinder, what would be your plan of action? Would you still go ahead and do radical surgery, or would you shift the treatment option to conservative surgery?
So with 3.5 centimeter tumor, probably I will still go in for a radical surgery only. But if the patient is too persistent, she still wants to preserve, we'll have to give her an option that yes, we can give some neoadjuvant, shrink down the tumor, and then try for a conservative surgery, but I will still go against it and will prefer still a radical surgery, and probably she can do, we'll preserve the ovaries anyways, or they can get a embryo preserved and get a surrogacy done later. But with this, I would, with 3.5 centimeter, probably I'll not be much in favor of doing a conservative surgery.
Okay, let's say that this patient had a tumor maximum dimension of 2.5 centimeters.
So less than 2 the trachelectomy is a good option. More than 2 centimeter trachelectomy is not a very good option in these cases.
Okay, so let's say it was 1.9.
Then definitely we'll offer conservative surgery for her, sir. She's 2 centimeter, 32 years, wants to preserve fertility. And if on MRI, yes, we can get a sufficient margin from the internal os, then yes, definitely a radical trachelectomy should be offered for 1.92 centimeter tumors, not a simple.
Okay. So your choice is radical but not simple.
Yes, radical trachelectomy with pelvic lymph node dissection also.
Dr.
Okay.
So there's a question in the question back. There are two questions. One is, what about sentinel mapping from Dr. Momita Bag? And another question from Dr. Minal Iyer. How does grading of biopsy differentiate any treatment outcome, or does it have any impact on investigation?
So Dr. Satinder, would you like to take the question first about
first about the
sentinel
sentinel
node?
lymph
Sir,
node. So
Dr.
there
Rohit is
are,
around.
Yeah. Okay. Welcome, Rohit, to the panel discussion.
Hello. Sorry for joining late. I was under the impression that the panel is next.
Okay, no worries.
Yeah.
so coming to the sentinel lymph node, so there has been a Sentinel study 1 and 2, and then there has been a Centix trial also in CA cervix. So definitely sentinel lymph node is feasible in CA cervix. However, what they had seen in the Centix study was that there were around 50% cases of false negative, on the frozen section. So basically, when we do a sentinel lymph node in endometrium, we do not do a frozen section. If the sentinel later on comes to be positive, it is considered positive and we continue with the hysterectomy in any case. But in cervix, the question is different. If the patient is node positive, we are supposed to abandon the hysterectomy. But since the false negative rate of frozen section is very high for sentinel lymph nodes in CA cervix, so as of now, sentinel lymph node dissection is not recommended for CA cervix cases. And the second question was, sorry, about the grade.
About grading of biopsy.
Grade of the tumor, as such, though it is not included in the adjuvant criteria for, we basically have to, our main aim of doing surgery or radiation, we have to avoid a dual morbidity. So though grade 3 tumors were not involved in the Sedley's criteria itself, but in the original study of Sedley's, they had taken grade 3 as a high risk factor. So if it is a poorly differentiated carcinoma, squamous cell carcinoma, it is grade 3, then we usually take that there are, and it has associated factors like, suppose this patient did not have LVSI, the LVSI is positive and the tumor size is borderline, we usually think that she will require adjuvant radiation later on, and then we focus more towards radiation rather than towards the surgery. So as per the grade should be limited, I think.
Yeah, thank you, Satinder. Just to rope in Rohit actively into the discussion, we are looking at what are the options for fertility sparing treatment for a patient who is 32, married, wish to conceive, and tumor size is 2 centimeters. So would you just go through the guidelines which are available? And I have put a slide on the recent ESGO Astro ESP guidelines 2023 for your support. So can you go through this indication, Dr. Rohit?
1 minute. I'm not able to see the slides. Yeah. Now I can see. Yeah. Okay. That's so. So basically, I'm sure these all points would have been covered. So one is that another important point what I would like to make is when somebody is very, very keen to preserve fertility, the other obvious factors which are needed for fertility also have to be ruled out. That is what is one more criteria. And again, MRI should be done in all cases, and this would have been discussed. And as of now, as Satinder has said, that it's still radical trachelectomy, which is the procedure of choice. Though there have been some reports especially after the SHAPE trial, that a simple trachelectomy may be a non-inferior modality compared to a radical trachelectomy. So, but there again, as you have rightly pointed out in the slide, the presence of LVSI is most important. And SHAPE trial was quite a well super selected population. All of them had a cone prior, and the cone needed to have a LVSI negative status for them to be eligible for the SHAPE trial. So it's not that you can tomorrow you can get up and start offering simple trachelectomy or simple hysterectomy to all patients. It's a very, very highly super selective population which only could be offered a simple hysterectomy as per the SHAPE trial.
Yeah.
Sir, Dr.
So for
Talreja
the
is around,
benefit
sir.
of for the benefit of all the participants, the flow charts where the line is continuous, these are the flow charts where definitive treatment has some evidence in terms of offering the treatment.
Recording in progress.
Whereas the dotted lines are the lines where you could have a shared decision making with the patient with the risk that this may be suboptimal. Number one. Number two, the evidence is going to be weak. So if you see in the lower panel, more or less radical trachelectomy is recommended for larger tumors, and for smaller tumors, if a patient wishes to undergo treatment surgery, then simple trachelectomy for T1A and T1A2 is recommended. But what is important is LVSI status for the patient who has undergone cone biopsy. Reporting is very important for these patients, and you should get back to your pathologist to find out whether there is LVSI, yes or no. And before that, the most important factor is lymph node staging. And lymph node staging has quite a significant bearing on the treatment modalities. And if the lymph nodes are intraoperatively positive and frozen is positive, usually the trend is that you should go for definitive chemoradiation with standard of care image-guided adaptive brachytherapy. Whereas lymph node negative, then the fertility option should be discussed and executed. And this is more or less an
Recording
consent which is
stopped.
taken intra-op.
Sir, can I just make a point? I don't know if this was
Yes, please
discussed.
go ahead.
I
Yeah.
think another very important point is to do a proper MRI in this case when you are offering patients
Yes.
a fertility preservation, because primarily you know that you are going to resect the cervix, and then you are going to anastomose the rest of the remaining part of the uterus to the vagina. So the upper endocervical canal has to be free. So that has to be uh, made sure both in the MRI and also during surgery. You have to check, because you have to have at least a 1 centimeter margin for you to suture. And because if the margin is less, if the distance is less, then they will have cervical incompetence. And it does increase
So
the
one of the
chance.
major,
Yeah.
yes, one of the major component of the treatment apart from trachelectomy is the cerclage, and for
Yes.
that you need 1 centimeter normal margin at the superior level. That's right. Thank you, Rohit, for that a very critical point in surgery. Satinder did mention that if this patient desperately desires a fertility sparing surgery for a 3 centimeter tumor, she did mention that in such situations, you could discuss an option of giving neoadjuvant chemotherapy for this patient, shrink the tumor, and if there is adequate shrinkage to the extent that you are able to perform a radical trachelectomy post chemo response, then you could offer this patient a conservative treatment. However, the data is very sparse and there is no robust evidence in favor of this, but this has to be only discussed in a very shared decision-making discussion with the patient and their relatives. Okay, so let's move on to the next important point. Let's say this patient underwent, let's say, a conservative cone, and followed by she conceived, she became pregnant, and she still has invasive cervical cancer. So, what would be your approach, Dr. Rohit and Satinder?
So, so in a situation where now the patient is already pregnant and she has a cervical cancer.
Yes.
Right, sir? If I'm not wrong.
Early stage cervical cancer. Yes. It's 1B2, T1B2, tumor size 3.5 centimeters.
Okay. So primarily, I think the desire to whether to continue the pregnancy or to whether to terminate is of paramount importance. You need to discuss with the patient as well as the family that whether they want to continue the pregnancy or they don't want to take any risk, and the disease control is of paramount importance. In that case, the situation, you should advise them pregnancy termination and then either proceed for a standard surgery or a CTRT, depending on the expertise and the stage at which the patient presents. Now, in a situation also, it depends upon what is the gestational age at which the cancer is diagnosed. Now, in a situation where the gestation age is quite, I mean, if the fetal maturity, for example, if the gestational age is quite early, then I would have doubts regarding offering them a fertility preservation in somebody who is already pregnant, because especially first trimester, if you offer them a conization or even a trachelectomy, the chances of miscarriage are very, very high. At the max, there are some isolated case reports that you can offer this in a second trimester, but I personally would not be very keen. So in early trimester, if the patient has presented in first trimester or second trimester, I would be more keen to offer them a sort of pregnancy termination and then plan for a definitive treatment for the cancer. If the patient has presented late in the trimester, then we would try to take the pregnancy to as much term as possible. Say if somebody has presented under 33 weeks, 34 weeks, nowadays the survivals in neonatal ICUs have improved than what was previously, and babies as early as 33, 34 weeks are also having a good survival. In that, the goal would be to take the pregnancy to as term as possible, may not be to full term, and then to plan for a C-section and then a cesarean over them in the setting, in the same setting.
Okay, thank you, Rohit. Anything you want to add, Satinder?
So I agree with him. Probably we will not give an option of trachelectomy in the early trimester, and based on the trimester settings, we'll have to do. But I have one question for you. If we are planning for, like, it's an early pregnancy and we are planning a radiation therapy, chemoradiation, definitive chemoradiation for her, would you like the patient to have an medical termination of pregnancy before CTRT, or if you are okay giving CTRT, taking a proper consent from the patient that she will undergo an abortion?
So maybe Harjot and Vinita can make answer this in one statement.
It is always desirable to do the termination of pregnancy first, followed by CTRT.
Yes.
I agree.
Yeah. So Satinder, very simple that we definitely go for MTP first, so that the uterus shrinks, the contents are emptied, and then we start with chemoradiation. That's the usual norm. Otherwise, majority of the
We
times
had a
we
similar
never.
patient, but nobody was ready to give her termination also, because the tumor size of that patient was around 7 centimeter. So she was 1B3, and nobody's ready to touch these patients for a termination also, because they bleed like.
So if it is advanced stage and the paras are fixed to lateral pelvic wall and everything is obstructed, then there is a problem of doing an MTP. In such situations, then we could take a special consent that we are going ahead with chemoradiation. Otherwise, most of the times we ask for termination first.
Yeah, or in that case, sir, an option is also, suppose in case the pregnancy is quite advanced, not advanced, but somewhere between, it may, if it is a second trimester or a late first trimester, then in that situation, you might have to go for a hysterotomy in a situation
hysterotomy is also an option. Yeah. So let's go to the heart of the panel discussion now. We did have this controversy. Surgeons saying you would go for radical hysterectomy with bilateral pelvic lymph dissection plus or minus ovarian transposition, and medical radiation oncologist said chemoradiation will be the treatment. So let's ask medical oncologists again who has joined the panel now. Maybe Rohit first. Rohit, 3.5 centimeters tumor, 1B2, 40-year-old, family complete, married. What would be your treatment choice for this patient? No notes on imaging.
No. So obviously it will be surgery.
Okay. So medical oncologist, Dr. Aditya?
I actually agree with the surgical colleague. 1B2 should be surgery probably.
Okay. So now, we all know most of the guidelines, whether it is ESGO, Astro, ESP, or NCG guidelines, or for that matter, NCCN. Very important is to make to have a multidisciplinary tumor board meeting choice of treatment should be determined by age, menopausal status, ovarian preservation, comorbid conditions, patient's wish, and availability of expertise in surgery and radiation is what it is recommended in most of the uh, most of the guidelines these days. So I just put down something for teasing the radiation oncologists and surgical oncologists here. There are a lot of recommendations which have come from various bodies. But what I'm putting here is there are so many conditions which are put into before you really recommend any treatment. So, but in reality, in clinical practice, this becomes very dicey and difficult. What according to me is that the lymph node staging is most vital, whether you are going to treat, whether it's surgery or radiation therapy. And that is what has been emphasized in these recent consensus guidelines also in 2023. So my question is, what efforts do you all do to find out and identify the risk factors in the multidisciplinary tumor board? Let's go to radiation oncologist first. How often do you discuss this in your tumor board that MRI is done for this patient and you identify these risk factors?
It is vital that we do MRI for these patients specifically so that we can identify the risk factors pre-operatively to avoid dual treatments. Like I said, we would like to see the correct tumor size and then see the stromal infiltration if accessible on MRI, and if there is any endocervical infiltration into the uterus which cannot be made out on clinical examination again, and rule out any parametrial infiltration. If on biopsy it is rare, but if we get information about LVSI, generally they give it as indeterminate. But if we can get information about lymphovascular space infiltration, I would definitely advise the patient to go for radical chemoradiation and not for surgery in that case. So these things are assessed, and for nodal assessment, we make sure that an imaging is done, either CT or PET-CT, to assess the nodes if the patient is for radical chemoradiation.
Yeah. So surgeon, Dr. Satinder.
So again, same starting. See, we have our main aim is to avoid dual modality. So we have to look for the parameters which
No,
basically
my
we have
question is
all.
not my question is not to identify the parameters. My question is, how often do you implement this in your tumor board when decision has to be done for such patients,
Sir,
whether
so we
radical
do
surgery or
implement, we
radiation?
do look at we do definitely MRI is done for all our patients to look at the size of the tumor, the parameter involvement, and we make sure that the pathologist also tell us about, we try our best that they tell us about the lymphovascular space invasion and lymph node assessment definitely. And in case there is a doubt on the nodes, because many a times it's nodes which is usually the problem. It happens that you see the shape of the node and you see whether there is the central, you can see that central fat thing is there or not, which are in favor of benign nodes or malignant. So we definitely try to have a look at the nodes specifically to see there is no nodal involvement. Usually it is the nodes which cause the problem, because parametrium and is usually with something which you can easily make out. So, but
Yeah,
in case you decide for surgery and the nodes are plus minus, if there is any doubt on pre-op CT or MRI, then we try and get an FNAC of the lymph nodes prior to surgery to prove whether it is benign or malignant, to decide that the mode of treatment.
that's right. So I wouldn't go to other people right now. But what I've shown here is that for the benefit of participants, lymph node staging becomes very important for these patients, which decides on the radicality of treatment. And if you're able to identify abnormal nodes on various imaging modalities, which is which may be MRI, which may be CT, or which may be PET-CT, and definite characteristics are seen, and if identified by radiologist, you should definitely decide on the treatment modality. And if lymph nodes are positive, the recommendations currently are definitive chemoradiation with image-guided adaptive brachy. If they are negative, then the options could be discussed between surgery and radiation. But however, one important aspect in surgery is that if during surgery, if you identify that lymph nodes are positive by virtue of frozen section or grossly enlarged at the time of laparotomy, invariably the evidence says that you should avoid doing radical surgery in such patients then abandon and close the abdomen and ask for definitive chemoradiation rather than proceeding with radical surgery. Of course, if the lymph nodes are negative intraoperatively, then you go ahead and do radical surgery. Satinder did mention that ovarian preservation has to be discussed with patients, but there are specific criteria which includes the contraindications include adenosquamous or adenocarcinoma, and then more advanced stages where patient may be at risk for metastatic lesions. Uh, After surgery done, then definitely you would go for risk stratification in terms of lymph node involvement, vaginal margins involvement, parametrium involvement, or the deep stromal invasion, tumor size more, then tries them into definitive radiation or tries them into adjuvant radiation or adjuvant chemoradiation based on the final histopathology. There is a recent study which was presented in ASCO 2024, and this was a trial where high-risk patients, cut margin positive, para-positive, or lymph node positive after surgery, were randomized to concomitant chemoradiation in adjuvant setting, and the study arm was chemoradiation followed by adjuvant chemo, something similar to Outback study. And what they reported, surprisingly, was that there was no added benefit of adjuvant chemotherapy in terms of disease-free survival or overall survival in these high-risk patients who have undergone surgery for early-stage cervical cancer. And this is a GOG 724 study. Obviously, the full publication is yet to be out. We would wait for the final results of this. Well, I was talking mainly on ESGO-ESTRO guidelines, but we do also have NCG guidelines. These are National Cancer Grid guidelines, which are adopted by many institutions across the country. And these are also in line with what we have discussed so far. So if somebody wants to really go into details, these are the guidelines which are available. I just wanted to add two slides on this famous landmark Landoni trial, where it compared radical surgery versus radical radiation. I don't want to go into these details, but what I wanted to highlight is what is shown in this slide. 20-year follow-up has been reported recently in 2017. And if you see 20-year overall survival in patients who have undergone surgery versus radiation, what I've highlighted in the red arrow here is as the tumor size increases from 3 to 3.5 to 4 to 5, and if you see the survival for surgery patients, it drops from 86 to 73. 13% reduction in overall survival if the tumor size increases from less than 3 to 4 centimeters. So in 5 centimeters. So it means the tumor size has a big bearing on the outcome in terms of long-term survival, overall survival. Whereas in radiotherapy, although not contemporary, the conventional treatments, there is no difference in survival irrespective of the tumor size. So my submission, and I would be in favor of discussing this with the patient as to what is anticipated over a period of 20 years from now, depending on which tumor size, we would discuss the options. And this should also be a part of discussion in multidisciplinary tumor board now with these outcome data from the first randomized trials which have been published. Second important point in this latest analysis was that for adenocarcinomas, the surgery arm did better. So it means adenocarcinoma histology is more aggressive. So maybe radiation alone may not suffice. So the rest all factors are more in favor of radiotherapy, whether it is squamous cell carcinoma or the disease-free survival as well as overall survival, more or less similar. So my take on this, if we have to discuss again in multidisciplinary, as discussed by both surgeons and gynae oncologists and radiation oncologists, we should be very careful in selecting patients who do best with single modality, especially when it comes to surgery alone. And this should be extra effort should be taken to make sure that you're offering the right treatment modality for that particular tumor stage as well as tumor type, depending on various other factors which have been discussed in detail. So my radiation oncologist colleague, can you highlight on what has happened post Landoni's trial in terms of giving chemo radiation these days with contemporary radiotherapy technology. Dr. Vinita to start with, and then followed by Dr. Harshwat.
So, Umesh, I might have, missed your question, but I think that the point that you're trying to ask is that what is the downside of giving adjuvant radiation after surgery? Am I right?
No, I'm asking about Landonis trial used conventional radiation techniques, but today you have state-of-art radiation techniques both for external and brachy. So what do you
Absolutely,
think?
absolutely.
Yeah, so do you have enough data to say that these two treatments are state-of-art today?
Yes, we have level one evidence to support the use of image-guided adaptive brachytherapy as well as use of intensity modulated image guided radiation therapy, both of which help in dose escalation. I mean, the brachytherapy, image guided adaptive brachytherapy helps in dose escalation to the primary, while the IMRT IGRT helps in dose escalation to the gross lymph nodes. And at the same time, there is a significant reduction in the side effects with the use of both these technologies when combined with concurrent chemotherapy.
Yeah, I just put on this slide of Embrace One study, which shows 1B1 and 1B2 more or less similar to what you would achieve with radical surgery alone. So my medical oncologists have been quiet for some time now. So my question to medical oncologists now is, this patient is 1B2. Why not neoadjuvant chemo followed by surgery?
So this question was long pertaining, and I believe the trial by Dr. Sudeep Gupta did uh, promoted the answer for the same, that the addition of the uh, neoadjuvant chemotherapy doesn't add anything to the treatment. It doesn't changes the margin. It doesn't have a local regional control, and specifically for this subset where definitive uh, therapy can be proceeded, it delays the what is the therapy needs to be done. So only for I believe a very specific subset, specifically for a very large tumor size, specifically for the greater than 4 centimeters parametrial invasion and pelvic lymph nodes, where the neoadjuvant chemotherapy has shown that yes, there is benefit of downstaging the tumor, improving the surgical outcomes, and improving the chances of complete resection. Does the addition of neoadjuvant chemotherapy to play a very important role?
And Dr. Aditya?
No, I agree with Dr. Vikas. In this setting, definitely no neoadjuvant chemo. Although it is quite interesting that both the keynote A18 and Interlace did include 1B2 in their inclusion criteria. But I think the 1B2 is still too early for us to think about neoadjuvant. Standard CTRT should be quite reasonable, sir.
Yeah, thank you, Dr.
Can I
Ramesh. But my
add
question to you,
So can I add
I will come
something?
back to you, Satinder. I'll
Yeah.
just come back to you, Satinder. So my question to medical oncologist is that earlier I mentioned about pregnancy. So if this patient opts for neoadjuvant chemo followed by conservative surgery option, what chemotherapy schedule would you advise?
So I believe there are latest advances. The addition of immunotherapy to the conventional chemotherapy, specifically if we have to give in a uh, locally advanced setting, not in an early setting,
I'm
is
asking about early stage where conservative surgery is not a treatment option. So to make a conservative surgery possible so that this lady can conceive subsequently.
so downstaging the tumor that and improving the surgical outcomes. Yes, that that's possibly for the fertility preservation where the aim is right now going to. Where in these there is definitely the 3 weekly regimen for a taxane platinum combination is there, or a cis-5-fu based combinations depending upon individual preferences.
And they are
Both have
safe,
shown
and they say they are safe during pregnancy.
uh, then it becomes a bone of contention at the same point of time. But yes, they have documented, especially in the second and third trimester, they do have specifically safer role. That's it, Wade.
Yeah, so there are only small series which say that Paclitaxel is safe after in second and third trimester. No congenital anomalies reported, and a success rate, fertility rate in the range of 40 to 50% is what has been reported. Yes, thank you. Yes, Satinder, can you make a point?
The point I wanted to make was that what we are talking about 1B2 today was not the 1B2 when the TMH NSCT study was conducted. So the tumor
Correct.
size what we are discussing is 3.5 centimeter, which is between 2 to 4, which was at that time 1B1, and that subset
That
of
was not included.
included in this study.
Yes. Okay, so your contention is that we should not offer neoadjuvant chemo
There
at
is
all
no need of
for this
offering
patient.
NSCT in a less than 4
Yeah.
centimeter tumor, no LVSI, no parameter involvement. We can directly go in for surgery. We don't need a neoadjuvant chemotherapy anyways in this patient.
So the only indication for neoadjuvant chemo would be if this patient is pregnant
Wants
and
a fertility preservation,
wants
then
a
we can.
fertility. Yes, excellent. Thank you. So you did mention about Interlace and Keynote 18, but unfortunately this is not in the scope of today's panel discussion because this is confined to only early stage, and these two trials have been more in advanced stage and more high risk patients. So I would not go into the details of this, maybe in some other forum sometime. Thank you very much. So the last question is, now that we are at the cusp of which treatment modality this patient has to be offered, question to both radiation oncologist and gynae oncologist. This is the incidence.
We have two questions. So can we just discuss before we proceed?
Sure. Go ahead.
So one question is from Shiva Kumar Mahalingam, wants to know about open versus minimal invasive surgery in radical type 3 hysterectomy. And then we have another question from Dinesh M. Should the factor in high probability of LVSI and deep stromal when the size is 3.5 centimeter, leading to post-operative with no gains from surgery? I mean, it just wants to know, is there any way of identifying pre-op factors?
Okay, sure.
And avoiding surgery.
First question, maybe Rohit, would you like to come to this LAC trial?
So as far as recent data from LAC trial is concerned, and that's probably the only randomized data that we have till now, which is comparing minimal access and open surgery in early cervical cancer. So according to the trial, more than 2 centimeter tumor, as of now, you should offer them open surgery, because LACC trial has shown that for more than 2 centimeter tumor, minimal access surgery is inferior. Although there are a lot of caveats in that study, and there are a lot of other data, retrospective, non-retrospective, prospective, single institution, which have been sort of debating the trial. But if you go from randomized evidence of whatever is available as of now, you should not offer a patient who has more than 2 centimeter tumor minimal access surgery outside a trial setting.
Thank you. Satinder, one line statement.
I agree with Rohit. So as per the guidelines, open surgery is the method of choice in this.
Okay. So second question was, as I asked in the MDT, that how often do you identify these factors? Deep stromal invasion, tumor size more than 3 centimeters obviously is known, and LVSI to decide on the treatment is what Dr. Dinesh wants to know. Dr. Harjot?
So preoperatively doing an MRI is the best way to analyze the tumor size at the depth of stromal infiltration. Lymph node assessment is one thing that we would like to do initially. PET-CT is the most sensitive modality, but if not, then you can go ahead with CT abdomen or MRI abdomen and pelvis. And LVSI is something that is difficult to report unless a conization has been performed previously on a biopsy specimen. It would be indeterminate. So I would go ahead with factors like the tumor size and the stromal infiltration and the lymph node status to decide whether the patient would benefit with surgery, or we should straight away offer radical chemoradiation if we feel that the patient may land up with adjuvant radiation later on. In this patient, the size is 3.5 centimeters, so my preference would be definitive chemoradiation, because as we discussed in the Landoni paper, the cutoff was tumors which were more than 3.5 centimeters had better outcomes with radiotherapy and not surgery. So unless the tumor is less than 3 centimeters, I would prefer going for radical chemoradiotherapy.
Okay.
Sir, can I just make one point about the imaging? One
Yeah.
last. So,
One statement. Yeah.
we are all stating about the imaging, whether it is MR, whether it is CT or PET. I think the quality of reporting and the quality of imaging is also very, very important. It may not be standardized across our country. Just a node being picked up on PET doesn't mean that it is positive all the time. We have in our country, the incidence of tuberculosis is significant. The incidence of parametritis or infection is significant. Sometimes a post procedure, when a PET or an MR is done post biopsy, we see a lot of small inflammatory nodes which may pick up and may be thought to have the patient may thought to be a node positive. So I think good imaging, good reporting is also something which is very important than just to rely on the report and just call somebody as positive.
Okay. So point well taken, Rohit and Harjot. It is obviously very difficult to sit in MDT and identify these factors, except for maybe LVSI. But as Rohit said, if you are a cancer center and you have a multidisciplinary team, then you could make sure that the radiologist standardizes the MRI for such patients and come up with this template protocol where they have to define the tumor size in maximum dimension. Depth of stromal invasion has to be defined. There are special series where they go into seeing what is the exact depth of invasion. LVSI is still a major issue, but if these two factors are there, then the chance that this patient would require adjuvant radiation becomes even higher and higher. But nevertheless, this is again, as Rohit said, depends on how evolved your multidisciplinary tumor board is. Having said that, it's very difficult, but if this patient is offered surgery, as I mentioned, well, definitely you should go for lymph node dissection or sampling first. If they are positive on frozen, then abandon the procedure and go for chemoradiation rather than continuing with surgery for such patients. Well, the last question to the panel, since we are running out of time, is very crucial section. Experts, Dr. Satinder, Dr. Rohit, expert gynae oncologists, one sitting in Delhi, one sitting in Bangalore. Radiation oncologist expert, Dr. Vinita Goyal and Dr. Harjot, one sitting in Hyderabad, one sitting in Delhi. Now, question is, can Dr. Rohit Satinder be everywhere in the country to do radical surgeries? Can Vinita and Harjot be available everywhere to do good radiation therapy and image-guided adaptive brachytherapy for equal outcomes? Let's start with surgeons. Dr. Satinder.
The surgeons can go anywhere. The radiation machine can't move.
No, I'm not asking about surgeon. I'm asking about gynae oncologist, not gynecologist.
So I think with no, I'm talking about
Do you have adequate number in the country to do radical surgeries?
So we definitely do not have adequate number of gynae oncologists, but with increasing number of seats in gynae oncology and the DNBs and MCH trainings increases and the fellowships increasing, yes, the number of people are increasing, but definitely the number of people as of now, what is required for our country are much less. And we need more.
Related to the same, do you have adequate pathologists who do frozen section?
No, sir. Adequate pathology, adequate radiology is also not there.
Radiology is
yes. So now, Rohit,
and also, sir,
take?
I think sir. I mean, as Satinder has rightly said, the number of graduates in all the subjects are increasing. But what's also is important is what is the quality of training that we are able to give them. That is also something which is important. I think, if I am not wrong, the surgical volume, say for example, a radical hysterectomy, the surgical volumes which are available in an apex center has reduced significantly what a trainee is being exposed to. So it's not just about the number of trainees or the qualification which is important, but I think the quality of training is also something which is very, very important.
Yes, so we have certain guidelines now. For example, ESGO quality indicators. I think there are people who are also worked on ESTRO guidelines. So radiation oncologists, expertise, machines for early stage cervical cancer. Harjot, and then Vinita.
So it is very important for us to have the expertise, because if we are talking about equal outcomes and less morbidity, then we need to deliver quality treatment, which would be in the form of image guidance when we are doing EBRT along with strict protocols, and image guided adaptive brachytherapy. That is where the entire curative rates of local control of more than 90% has come from. So we definitely need a high quality technology and expertise in image guided adaptive brachytherapy if we have to achieve the outcomes that we read in the research papers and we quote to the patients.
Dr. Vinita Goel.
I think there is definitely a lacuna, but then, as is true for all specialties, the machine availability across India, expertise availability, DNB seats, everything is increasing. So we are hopeful that the gap will get fulfilled, in coming times. But right now, we
Okay.
do not have adequate resources.
Okay, sure. Thank you. So with this, I would like to say conclude this question with a very positive note that for both gynae oncologists and radiation oncologists, that we are hoping that the quality of surgery, the number of people who do this surgery, number of people who would be available for treating these patients in radiation oncology, pathologists and radiologists, in times to come should definitely improve for treating these cancers. Plus, also positive finding, which Rohit mentioned, was that the incidence of cervical cancer is on a decline. Nevertheless, we also are seeing a lot of downstaging. We no more see very advanced stage disease, and we are seeing more and more early cases. So it is very important that we offer the best treatment for these patients, and it is very important, equally vitally important, that the specialists are also trained in a similar fashion, so that these treatments are offered at the doorsteps of the patients, where patients are seen in the rural background. So I would like to conclude this panel, and I'm sure the panelists will agree to the conclusions and summary which I've mentioned here, that any patient of cervical cancer definitely deserves an appropriate evaluation and staging, apart from biopsy and examination. And there has to be a joint multidisciplinary tumor board discussion for every patient of cervical cancer now that it is on a decline, and less and less patients are going to be seen in the clinic. Of course, for early stage cervical cancer, the discussion has to be the treatment options based on the tumor size, based on the different factors which have been discussed today. More importantly, discuss the outcome in across the table with the patient in a more scientific way. And very important is always talk to the patient about the morbidity. And last but not the least, I think the time has come in India that we do have to have a shared decision making, involve the patient and the relative in finalizing the decision, rather than the oncologist who sees the patient first taking the decision of doing the offering the treatment. With this, I would like to conclude this panel and thank all the panelists for active discussion, as well as the participants who put in a lot of interesting questions. Once again, thank ISO for giving us the opportunity, and looking forward for many more meetings and panel discussions in an online mode. Thank you very much. Over to you, Dr. Richa and Dr. Arvind.
Yeah.
Thank you.
Thank you, Dr. Umesh, for such an informative, evidence-based panel discussion on the management of early cervical cancer. And as we are already running short of time, I now request Dr. Vijay Kumar sir, Chief Surgical Oncology and Vice Chancellor, Enipoya Specialty Hospital, Mangalore, for his expert comments and the concluding remark.
Thank you very much for calling me. I thank the organizers, Dr. Toprani, Dr. Arvind, and Dr. Sabita, for inviting me to be there. Though I joined a little late, but I was very much there. Only thing I would like to say in a summing up, that you people have already discussed, but anyway, it will be a repetition, I know. As such, the incidence is going down, reasons unknown. For example, if you go by Globocon and 100 women cancers, you see earlier it was earlier it was cervical cancer, which was topping the list. Today it is breast cancer, which is 26 out of 100, whereas cervix is 19 out of 100. That is number one. Whereas if you take the rural and urban division, still the rural is continuing to have this. And that is why we are concentrating. And in fact, I am leading a team at my Anapa University and also an ICMR project where we are trying to do the cervical, oral, and breast cancer. Implemented research is going on. And why this is very important is it is relevant to what the conclusion, what the moderator made, saying that early you come, then the chances are better or cure, and then only the question of either you are giving radiotherapy or surgery, such discussion will arise at all. During my days, I am talking about 40 years ago, I completed 40 years on 26th of December last year. We used to see stage 3B. The question of cancer cervix coming to the table was such a problem at that time, and by default, it will go to radiotherapy and it is a palliative radiotherapy, etc., etc. Whereas slowly the scenario has changed, and we are talking about early detection. The coming people are coming early, and we are talking about stage 1, what to do with stage 1B, whether to do surgery, etc. To that level, we are discussing. I'm very happy because such early diseases were unknown in 30, 35 years ago. That is the first change which we are seeing. Second thing is which we have to know. I don't know how many youngsters have seen the cobalt treatment days, the treatment of the same radiotherapy. You believe it or not, the severe proctitis and the radiation-induced cystitis, we used to sit and treat them. And I have done even colostomies for those patients those days. Whereas we hardly see any one of them, thanks to the technology and the planning, etc., etc. With respect to radiotherapy, you hardly see such side effects today with respect to radiotherapy. So the point I am making is radiotherapy on one side, technology as well as technique is improving with the least side effects. On the other hand, we are getting early disease. And so the balance is now totally, the pendulum is swinging towards radiotherapy, which we have to all accept it. And probably the surgical oncologists and gynecologists are going to be to get ready for a different skill sets is what I would suggest. One side, we have to probably, we don't do that many radical tracheolectomy, which probably we should get ready with that to save the uterus. On the other extreme, the involvement after the radiotherapy failure, particularly the central failure, if you see, where we have the surgical group has to get ready for a radical surgery, much more than a radical hysterectomy. What I mean is, I am talking about the excenteration procedures, whether it's posterior or total excenteration. These are the things which probably the skill sets have to change as far as surgical team is concerned. Coming to the who will do the camps and you have to get them early is the point. And we are trying to tell that number of gynecologists and number of gynec-oncologists, etc., are less. But whoever is holding the fort, but ultimately it's our business. You are expecting somebody other person to go and do, and then they will bring the early cases. Should change. We, as a total oncology, we have to behave. We have to take the responsibility of doing the community outreach programs as well. And the last but not the least would be the coming up the role of HPV vaccination, which which is picking up even in our country, and it has become cheaper because of the Serum Institute ones which has come down. And somebody was talking about radiotherapy. I had the opportunity to talk about cancer, affordable cancer care in India and the ARY. And for that, when I saw radiotherapy machine requirement or the available today by data is in USA, it is 76 per crore population, whereas in India, it is 4 per crore population. And it just compared with at least a large country like China, even there it is double. That is 8 machines are available for 1 crore population, whereas US it is 76, whereas ours is 4. That is the need where we may have to improve the numbers first, then the expertise, and lastly, the decision making. The decision making has to be, as somebody lastly, the moderator very nicely said, it not only MTDG, that is not only the multidisciplinary treatment group, but it has to be a shared decision with the patient and the relatives. If that is not done, we are going to face a lot of problems. Last but the least, about what we are talking about, the minimal invasive surgery. Minimal invasive surgery is still going on with people. We are doing it, and many people continue to do it. But on whom we are going to do, is the only point. And that is where the randomized study has proved it. And we have to be careful in talking about it. If the expertise is there, whether robo or conventional laparoscopy, we may have to confine ourselves to a very small tumor, if at all necessary. Otherwise, the evidence is not in favor of it. But that should not stop us from doing it in a trial basis. Otherwise, one fine morning, somebody says, now you can do minimal invasive, then we cannot do. So it is better that we enter into some clinical trials and do it in a trial setting so that we don't lose the skill sets about the minimal invasive surgery also. And that's what I would like to conclude, giving me an opportunity. Thank you very much, Dr. Toprani and Dr. Arvind and Dr. Sabita. And thanks a lot for this opportunity to be with you all. Thank you.
Thank you, sir. But before we conclude this webinar on cervical cancer, there is a very important question, very pertinent question from the audience. We all know we have talked about the developments in technology, surgical techniques. But the question is, do you think we have managed to educate the Indian rural women about the perils and precautions of cervical cancer, and also regarding the, the HPV vaccine hesitancy? Dr. Umesh, would you like to answer this question?
Well, as you all know that I have shifted from Mumbai Tata Hospital to Andhra Pradesh now, Visakhapatnam. So what we have done is over a period of 18 months, we have trained practically every mid-level healthcare provider and the medical officer at rural level with training material being how to screen for common cancers. More important weapon is the health education to be imparted. And this is becoming a success story because we did a pilot in our district next to Visakhapatnam. And today I can tell you that more than 10,000 population have been screened, and screen positive have been tested for further diagnosis, and majority have been also treated. So with this pilot success, I think in Andhra, they are more or less doing now screening and health education for entire state, which is planned now. So on similar lines, maybe many states, if they undertake such activities, I'm sure one day, like the way we have addressed HIV prevention program, if this also comes into the health education part, health sector, I'm sure cervical cancer will be a minor cancer very soon.
Thank you so much, sir.
So thank you, sir. Thank you, Umesh, sir. And thank you, everyone. So it was a nice panel. And so the next announcement from our side is many of you might be knowing that we are doing these webinars every fourth Wednesday of every month. Although since next month, fourth Wednesday is a Mahashivratri, so we have shifted it to third Wednesday. And the next time the topic is on gallbladder and biliary tract cancer. So with this, I would like to end this session. I thank all the faculties and the panelists and the delegates. Thank you, everyone. Good night.
Thank you.
Thank you very much. Good night.
Thank you, sir.